For decades, the standard procedure for handling infectious outbreaks has relied on a simple trigger: waiting. Public health officials monitor clinical case numbers, watching and waiting until the sick begin to overwhelm a hospital waiting room before launching a response. When a vector-borne disease like malaria or dengue spikes, the reaction is often brute force. Because the exact breeding sites of the mosquito vectors are hidden, governments have historically relied on blanket insecticide spraying across vast stretches of terrain. It is costly, it taxes the ecology, and it frequently misses the most active clusters. The human toll of this delay is severe. By the time a patient in a rural community presents with a fever, gets tested, and waits weeks for a central laboratory to confirm the pathogen, the disease has already spread through the population or caused irreversible harm to the individual. Now, national health systems are moving away from this reactive model. They are integrating artificial intelligence directly into their infrastructure to predict and intercept diseases before a single patient shows symptoms. Shifting from a reactive sick care model to proactive population management allows health systems to focus on prevention before the high costs of hospital treatment and emergency spraying drain limited budgets. In endemic regions like Zanzibar, the proactive approach starts in the sky. Teams are launching autonomous drones to capture high-resolution multispectral imagery over vast terrain. This convolutional neural network processes massive volumes of drone imagery. High-contrast segmentation masks pinpoint subtle shaded water bodies, the exact mosquito microhabitats human surveyors miss. Ground teams receive precise GPS coordinates directly from the algorithm, navigating straight to these isolated targets. This environmental foresight extends beyond mosquito mapping. Platforms like Microsoft Premonition deploy robotic biological weather stations into remote areas. These devices draw in specific insect vectors, identify them in real time, and sequence genomic data to predict zoonotic biothreats long before an outbreak ever begins. Replacing reactive chemical clouds with AI-targeted eradication reduces localized mosquito vector densities by up to 40. Now, a non-specialist primary care nurse takes a picture of the patient's retina, and an on-device deep learning model screens for hemorrhages instantly. In Kenya, this identical framework is actively rolling out for oncology. Using automated visual evaluation on smartphones, health workers perform on-the-spot evaluations for cervical cancer. This screen-and-treat model eliminates the multi-week lab wait, removing the geographic and specialist bottlenecks that traditionally tossed rural patients their lives. AI is also working at the microscopic level. Developing vaccines for shape-shifting parasites like malaria is notoriously difficult because they deploy hundreds, sometimes thousands, of different surface proteins to evade the immune system. Researchers struggled for years to map the crucial infection-disrupting protein, PFS 4845. Then, DeepMind's AlphaFold AI stepped in, successfully predicting the protein's stable 3D shape. By accurately predicting these complex molecular structures, AI empowers scientists to proactively design vaccines. They can neutralize parasites in the midgut of the mosquito, stopping the human infection cycle before it ever begins. But there is a reality check here. Having the most advanced predictive algorithms in the world means nothing if the technology fails to survive the last mile of real-world public health implementation. The primary operational bottleneck is interoperability. An AI diagnostic app is functionally useless if its data remains siloed, unable to securely communicate with an existing national health infrastructure like the DHIS2 software suite. When systems cannot talk to each other, they force local healthcare workers into duplicate, manual data entry. Worse, they leave national ministries completely blind to real-time supply chain shortages or emerging outbreak trajectories. Beyond the software, there is an ethical bottleneck. Studies on drone use in Zanzibar demonstrate that deploying advanced technology into local airspace requires immense proactive community engagement to succeed. If global health organizations fail to recognize local power dynamics, bypass local governance, and neglect to build trust, these interventions are quickly rejected as paternalistic science experiments. True public health transformation requires marrying predictive algorithms with local community trust and seamless database integration, making proactive prevention the baseline for global medicine.